Okay, good morning, everybody. Thank you so much for coming. It's going to be a very interesting session. I am Josh Sharfstein, Associate Dean for Public Health Practice and Training, and it is my pleasure to welcome you to another exciting episode of the Centennial Policy Scholar Series at the Johns Hopkins Bloomberg School of Public Health. Thanks to our alumna, Frances Henkel, we have this program where we have had Congressman Henry Waxman, arguably the most accomplished legislator in public health in U.S. history here for the year, and now we're into the bonus time part of the year because we extended the centennial for 18 months, and he is extended for 18 months.
Extend another year.
Yeah.
4 more years.
And and over this period, we've had a number of seminars. All of them are archived online, as this one will be, on different topics that relate to the incredible work and career that Congressman Waxman has had. And at some of these, we've been able to catch up with some of Congressman Waxman's former staff who have gone on to work in many different areas of health policy, and that is one thing that we're doing today. I'm not going to say very much about Congressman Waxman and Dr. Cha because I'm going to introduce the Eugene and Mildred Lipitz Professor for Integrated Healthcare and the Director of the Lipitz Center for Integrated Healthcare, Karen Davis. Professor Davis will be moderating today's panel, but I will say that I've known Dr. Cha for quite a while. He is leading an incredibly innovative set of efforts that is dramatically impacting healthcare across the country, and it's really fantastic that he is in the job he is in, number one, and that he is willing to share time with us at the school. So I want to personally thank him for that, and with that, I will turn this over to Professor Davis.
Thank you, Josh, for that. We're really honored to have with us today two very inspirational public health leaders who I think you will agree have saved lives, millions at a time, very much in keeping with the motto of the school. Henry Waxman has been a stalwart of the vulnerable and the elderly throughout his 40-year career in the U.S. Congress. I had the privilege of working at the Department of Health and Human Services when the building was inaugurated as the Hubert Humphrey Building. And I've had a special fondness for Vice President Humphrey ever since I testified before his Joint Economic Committee, and my 7-year-old daughter accompanied me to that hearing, and he came down afterwards and asked her if she played hearts, and he played hearts with his grandchildren. But Hubert Humphrey noted that the moral test of government is how the government treats those who are in the dawn of life, children, those who are in the twilight of life, the elderly, and those who are in the shadows of life, the sick, the needy, and the handicapped. And Henry Waxman has met that moral test. He championed the landmark Affordable Care Act through the Energy and Commerce Committee and the House of Representatives, providing health insurance coverage to over 2 million uninsured people. He was the force behind the creation of the Children's Health Insurance Program, which now covers 6 million low-income children and pregnant women. He was instrumental in the passage of the Ryan White Care Act, which provides health care to people living with HIV and AIDS. I could go on to a lengthy list of legislative accomplishment, but I think it sums up his focus and determination to protect the public's health when Time magazine published a list of the top 10 corporate grillings in the history of the U.S. Congress. 4 of them were chaired by Congressman Waxman. His oversight of the tobacco industry forever altered the nation's perceptions of cigarettes and created history when, while chairing the House Energy and Commerce Subcommittee on Health and Environment, the nation's leading tobacco executives testified that cigarettes weren't addictive. President Barack Obama called him one of the most accomplished legislators of his or any era. So we're honored that he has extended this bonus period as the Centennial Policy Scholar in recognition of the anniversary of our school's founding. Dr. Stephen Cha is an innovator for the public's health who learned at the feet of Congressman Waxman. He served as senior professional staff for the Committee on Energy and Commerce under Chairman Waxman. He was responsible for a broad set of health issues, including quality, delivery system reform, workforce, comparative effectiveness research, drug and device regulation, and public health. And during his tenure with Congressman Waxman, he oversaw the drafting of multiple pieces of legislation, including sections of the Affordable Care Act, the American Recovery and Reinvestment Act, which included reauthorization of the Children's Health Insurance Program, as well as health information technology, and the Food and Drug Administration Amendments Act of 2007. He's currently Group Director for the State Innovations Group at the Centers for Medicare and Medicaid Innovation. The State Innovations Group includes State Innovations Model, and that has supported cooperative agreements to 38 states, territories, and DC to accelerate state-based delivery and payment transformation. The group of particular interest here in model supports all-payer models, such as the Maryland all-payer model. And in this role, he is overseeing ongoing transformation of the nation's health system. A lot of us focus on coverage of the uninsured under the Affordable Care Act and don't really understand all of the activities and provisions that really are changing the way healthcare is delivered and experienced in this country, with the goals to achieve the triple aim of saving lives, improving patient care experiences, and lowering costs. Prior to assuming oversight of the State Innovations Group, he was Chief Medical Officer of the Center on Medicaid and CHIP Services. He promoted health transformation and modernization of Medicaid and CHIP through delivery and payment reforms and quality initiatives. He was a Robert Wood Johnson Clinical Scholar at Yale, earned his MD at Brown University, a master's degree in health sciences research at Yale, and did his residency at Montefiore in New York. So join me in welcoming Dr. Stephen Cha to talk about healthcare innovation in Maryland and beyond. Thank you.
Thanks so much for that introduction. It's perhaps my proudest title to also be identified as a Waxman alum. It's a fantastic group of folks, and Josh is there with me. It's some of the best times in terms of having an impact and having an ability to really speak to what you care about and speak to what you think is right in the world. And I learned it from Henry, so I appreciate him being here today as well. I did want to talk about healthcare innovation in Maryland and beyond, and I'll start with the beyond and then come back to Maryland. And let me start with this. This is the ACA. This is actually I couldn't find something online. This is actually a picture from my basement, framed copy of the ACA. If I could scroll down, you'd see Henry's note to me in the corner. And I start here because when we talk about delivery system and payment reform for the national level, and I think just as Karen was just saying, a lot of folks focus on the fact that we have addressed major coverage issues with the ACA, and we have 20 million added to the rolls, lowest uninsured rate in the history of this country, amazing achievements in terms of moving forward. But I would also say the promise of the ACA was not simply coverage. It was not simply to get people an insurance card. It was to make them healthier. It was to ensure that they got better care. It was to ensure that the coverage was meaningful in their lives. And I think this is the piece that has become our new challenge in terms of understanding what it means in this world as we've expanded what do we do with this coverage and how do we make that meaningful? In a nutshell, and I think I'm going to come back to this at the end, I think what I want you to walk out of this room understanding is that the real promise of the ACA was, as we can cover everybody and bring people under a single system, we have the opportunity to make a system out of that. We have the opportunity to create a system with the right incentives, the right outcomes, and the right incentives to make patients and our beneficiaries healthier at a population level, not just at an individual system level. And that's a promise that I think that we have an enormous opportunity through state-based reform, and I think that's what we're going to talk about today. So this is one section that helped the ACA get there, and just to start with our framing of what our authorities are. This was an innovation center. It was created by the ACA to develop, test, and implement new payment and delivery models. And the purpose of the center is to test innovative payment and service delivery models to reduce program expenditures while preserving or enhancing the quality of care furnished to individual under such titles. And I start here because I think this was part of our crucial linkage as I was talking about that the promise of the ACA was not just about coverage. It was about improving care. It's also to highlight that we have a clear statutory mandate. And I'm not going to go through those three scenarios for success. It basically means we can improve costs or improve quality or both. The one thing that's not on there, and I think we were just talking about this with a smaller group upstairs, we don't really have the parameters to increase quality while increasing costs. And I say that because there's a lot of things out there that are absolutely valuable that increase costs and improve care. That's simply not within our statutory parameters. And so when we talk about what our framework and what we're engaged in, I want to be clear that there's a lot of stuff out there that we don't do, and that's partly because of our statute. So I'm going to talk a little bit about, so that was our ACA mandate. I'm going to talk about where the department is and where Congress is and how states fit into that picture, and that's the next few slides here. So this one is in January 2015, the department announced goals for value-based payments within the Medicare system. And let's just focus on that goal number one. There's a lot of stuff on the slide, but essentially the secretary said she wants 30% of Medicare payments to be in what we call alternative payment models. These are models of care where the payment is tied to quality or value in a substantive fashion. And she wanted to hit this goal for Medicare, 30% by the end of 2016. We hit that goal a year ahead of schedule. We're still on track. The next goal is to hit 50% by the end of 2018. And just stay with me on that top line for a second, because I want you to go to the right side, because the point was not just to say Medicare should transform. The point was to say the secretary is using her authorities and her bully pulpit to trigger this transformation, but this can't be done alone. And she wanted stakeholders to join her, consumers, businesses, payers, providers, and state partners to join her in setting these goals and to match or exceed these goals for transforming care. And in fact, we are. We're engaged with them in what we're calling the Healthcare Payment Learning and Action Network, which is a broad coalition, multi-payer, multi-stakeholder coalition to talk about what do we need to be doing to hit these goals across the nation. But fundamentally, I think the take-home slide for this is that it's the department and a lot of stakeholders saying, we believe that transforming towards these alternative payment models that tie payments to quality or value are really important to the department and to the nation. Not going to talk much about this, but to say Congress has reinforced that with the Medicare Access and CHIP Reauthorization Act. And in particular, what CMS is implementing and has proposed called the Quality Payment Program. And I reference this because there are in particular, and it's a long bill and a long regulation, over 900 pages in terms of the regulation just for the first proposed rule for the Quality Payment Program. Not going to go into all that, but what I do want to highlight is that Congress has also put real dollars on the table to promote these alternative payment models. In fact, there's a potential 5% bonus on your Medicare dollar if providers can get into and provide most of their care in one of these alternative payment models. And even more specific to states, that 5% bonus is available to models that are across multiple payers. So just think about that for a minute. Congress has put Medicare, federal Medicare dollars on the table to promote change in systems that aren't even Medicare. That was what Congress said because there is a fundamental belief represented in this act that says we should be continue on this journey to transform systems that can provide better care at lower cost. How is that working out for us so far? So this is just a quick heat map of our CMS innovation projects across the country. The blue dots are sites where we have innovation models being tested, and the red squares are models that are run at the state level. And you'll notice in some states there are more than one red square in a state. It's because we have sometimes a state partner with a particular site, and that might be more than one place. Point is that we have a lot of stuff going on around the country. I'm not going to go into all the various models that the Innovation Center is standing up right now, but just to say we have pretty good geographic penetration. We still have more work to do, particularly in rural areas, and we can talk more about that later. So let me talk a little bit about the state innovation models, and I'm going to finish by closing the dots between what the states are doing and that original promise of the ACA. So we have about $1 billion in cooperative agreements to states to test the ability of state governments to accelerate healthcare transformation. Again, these same things that Karen talked about, improving quality, improving health, improving cost efficiency. And this map, again, represents our, in blue, 6 round 1 model test states, and in green, 11 round 2 model test states. 17 states that we have a pretty substantive engagement with who are really trying to promote vigorous reform. This is the Maryland case. So this is your model in terms of thinking through what you're engaged in. You have a unique system that you've stood up in Maryland. You are our nation's only all-payer hospital rate regulation, meaning that at the beginning of the year, every hospital knows essentially what they're going to get paid for the remainder of the year. And as Josh himself said when he was Secretary of Health at the launch, we've now made it more profitable for hospitals to keep someone out of the hospital than to put them in that. So it's a radical change in how we pay hospitals. And testing whether effective accountability for cost and quality can be based on that per capita total hospital growth. So far, we've had pretty good results. In the first year, we've had $116 million in Medicare savings from that hospital. We've had 1.47% in total all-payer, again, not just Medicare, all-payer hospital per capita growth. And we're seeing improvements in the readmissions rates. So we're seeing good progress in Maryland in the first year, and 95% of hospital revenues are in the global budget. Just to say on this slide, we have a lot more work to do. And part of that deal and that condition when we signed that deal was by 2019, Maryland gets into what we call a total cost of care model. That sounds like fancy jargon. Essentially what that means by 2019, this is a hospital model. By 2019, we need that to be a broad, whole person, beneficiary-centered model. And we're working aggressively with the state to think about those next steps to get there. And happy to talk about that more in question. But I think this is the opportunity for us in thinking through what that vision really looks like, to think about a system and aligning the incentives of a system towards the incentives of and promoting the real health outcomes for an entire population. I talk to a lot of hospitals, and when we talk to them, they will often say, when we talk about our journey towards value-based payment and our journey towards holding systems more accountable for health outcomes, they'll say, we're totally on board, right there with you. Absolutely, we want to be paid for outcomes. Just don't hold us accountable for anything we can't control, right? And so I think there's a fair statement there, which is that we do need to structure systems that can, in fact, improve outcomes. But we have to do that in a way that is responsible and effective by pulling together the entire population. So what we have in Maryland, as opposed to think about an ACO in an isolated area, where there are multiple ACOs in the area and multiple other systems, and to hold one ACO accountable for the outcomes for that population, honestly, that probably isn't fair, right? If you think about that, their ability to actually affect the health of that population, they only have a portion of that population. But think about our opportunity in Maryland for a second. Think about our opportunity once we have everyone within a system, and everyone within that those denominators as the technical term, everyone in that idea of who you're responsible for. That's in the finances. We have an opportunity to, as we say, flip the business model, right? So to say, we're not going to incent you just for improving quality. We're not going to incent you for just improving outcomes. We're now giving you the tools to actually impact the entire population. We're also going to hold you accountable for that. And that's why I think this idea of state-based models, where we can get that penetration. In Maryland, we're going to have most of your population in some sort of model that looks like this. We are close to, in final conversations with other states, Vermont and Pennsylvania, where we'll have a majority of those state populations into a single system. then we have the ability to say to that system, well, most of the state is under your control now. We have an ability to say to that hospital, we're going to hold you responsible, but we're also going to give you the tools to actually impact health. So we often talk about how 80% of the finances, 80% of what happens and affects outcomes are non-healthcare system related. And I think that's true. And we can talk about whether we should shift more money to where that 80% public health is, or we can talk about how we can restructure the finances so we are all aligned in terms of trying to actually improve outcomes for the country. That's the promise in Maryland that we have to capture, and that's the promise that we believe is existing in state-based models. I'll finish with this slide, which is just to say Maryland isn't the only state we're talking to right now. We're talking to multiple other states. It's in the news that we're talking to Vermont and Pennsylvania right now. We haven't signed a deal with them, so I don't know whether we'll get there or not. But just to say, these are the standards that we talk about. We have to have patient-centered systems. We have to be accountable for the total cost of care and the full spectrum of care. It has to be truly transformative and has to capture most of the patients and providers in that area. And feasible to implement and evaluate. I'm going to close with this slide because I think this is not only the promise for other states in terms of state-based models, but also the promise of Maryland. When we think about these principles, when we think about what the future of Maryland can look like, that idea that we can really flip that business model around, that idea that the ACA promise was based not on coverage alone, but really ensuring that once we built the system, we could provide the incentives to providers and beneficiaries to actually achieve the health goals that we can achieve. That's what we can achieve in Maryland, and that's what I think we can achieve through the state-based models in a very unique sort of way because of that power to really have penetration and have everybody in within a state. It's that possibility that you have in Maryland and that possibility that we're continuing to work with you all. So I have to take more questions. I think we're going to have a conversation, but let me leave it there for now. Thanks so much.
Thank you. I was particularly struck in that last slide by the use of the word transformative. And I think what we've seen in the first 6 years of the Affordable Care Act is lots of innovation, trying a lot of things, some of those through the Centers for Medicare and Medicaid innovation, some through waivers, some through campaigns. CMS and the Department of Health and Human Services have mounted. I think people are now kind of looking forward to how do we build on that period of innovation, wedded with scientific evaluation of impact and outcomes, and as Dr. Cha has emphasized, on cost. But how do we go forward? Do we want to keep trying, some people saying, 1,000 flowers blooming? Or do we hone in on things that are the most promising? So to kick off the discussion session, I really wanted to ask Dr. Cha what he views as the most transformative, and really how do we move forward over the next 5 years in focusing on spread, scaling, generalizability of what we're learning.
I think there are a couple of different ways that certainly the Innovation Center is engaged in that, which is, I think we need to identify the right tools. So, and by that I mean, I think we have work around patient-centered medical homes. We call it our Comprehensive Primary Care Initiative. We have work around accountable care organizations with our pioneers and soon our next generation ACOs. What does it look like to develop systems and sectors that can perform better? We have our bundles working and being tested right now. I think in part our next question is really, how do we think about how these models work together? How do we think about, I think we often talk internally about this sort of idea of overlaps as if it's a negative thing, but I think we think a lot about what's the synergy? How do we actually think not just how does this ACO work in isolation and try and separate all the other impacts, but embrace that spread that's happening today. We're seeing more and more models start to be in the same geographic areas. How do we help them work together? How do we make sure they all have the right incentives and they're all aligned? I think that's to some degree the next challenge, and it's sort of our next generation for some of our Innovation Center work. And I think what we talk a lot about with our state partners in the specific state models we do is what models do you have? How are they working together now? How might we promote that collaboration in the future? So I'm excited about the progress we've made to date, and I think the future is really trying to put some of these pieces together in a meaningful way.
Congressman Waxman, you were instrumental in creating this baby, this child, the Center for Medicare and Medicaid Innovation. It's pretty unprecedented to get $10 billion to really test out a number of approaches to payment and delivery system reform over 10 years. I don't know if you saw the New York Times article by Robert Pear a couple of days ago, Sunday, where he mentioned that the chair of the House Budget Committee is concerned about the authority that CMMI has and potentially trying to defund some of the money that still exists for the CMMI to pursue this. And he's particularly concerned about a provision Dr. Shaw had in his slides that if the Office of the Actuary finds that a particular model lowers costs or improves quality or does one or the other without harming the other, that the department, the secretary, has the authority to spread that more broadly in the Medicare program without going back to Congress and changing the way we pay. And I think we all are watching, we all know that the chair of that committee himself is an orthopedic surgeon. So as CMS moves forward toward bundled payment for hip replacements or other orthopedic procedures, obviously that's being watched closely. But do you think there's bipartisan support? That's basically my question, Congressman, for CMMI.
Well, I wondered when we adopted the ACA whether there would be bipartisan support. And this is unprecedented, to try innovations and to do demonstration projects, involve the states. The law that most people focus on is the extension of coverage, that we were going to provide exchanges and competition between insurance plans and make sure that people could get access to care that couldn't in the past for the obvious reasons. They had pre-existing conditions, they were discriminated against by the insurance companies, or they just couldn't afford it. So that has been the main focus. But in adopting the ACA, the Affordable Care Act, and some of the changes in Medicare, we thought this would impact all the delivery of care, whether it was employer-based, Medicare, Medicaid, the CHIP program, and the individual insurance policies. So the question to me, I'm going to turn around and address it to you, has this been successfully received on a bipartisan basis? Because my impression is that while so much of this law was partisan, the idea of the Innovation Center has been well received by people in both parties. And in fact, maybe this was after Robert Pear's article, but the House Budget Committee held a hearing, and you could tell us, how were they responding to your work on that committee and with other Republicans as well as Democrats that you've been talking to in the Congress?
So maybe thankfully I don't talk to much Congress these days, but as much as I used to.
I don't either.
But I will say, in terms of, I'll take it one step back, which is just to say, we clearly work with people across the political spectrum, both within our individual models and in particular within the State Innovation Models Project. We are working very closely with Republican governors and Democratic governors, and I kid you not, I honestly sometimes forget in terms of that, say, Massachusetts or Maryland has had a party change. And some of the work carries on in such a seamless fashion that there's such a commitment from stakeholders. We see just dramatic progress across the nation and dramatic alignment in terms of various parties and entities and people across a political spectrum in the nation at large, supportive of our work and wanting to work with us. What that means for Congress, I think I probably won't speculate on, but I will say it's very clear from at least our day-to-day work and our day-to-day interactions that there's broad support for what we're doing. And we are seeing results in terms of the innovation center models. We are seeing improvements in care. We are seeing changes in the trend of costs. And so I think that alone underscores why we're continuing to move forward. I will say one thing, which is that with regards to that budget hearing, part of the focus was that we do have a $10 billion outlay over 10 years. CBO has scored us at a savings of $43 billion, so netting $34 billion in savings for that $10 billion. What that means is that to cut CMMI, the Innovation Center today, it is in essence what we used to call a pay for. You'd have to actually pay to take that money back from us. I think that was part of what the House Budget Committee was not so happy about, but at the same time, at least from, and again, I wasn't directly in those conversations, but there was a clear sentiment of support there as well in terms of support for the work we're doing and support for the models we're running.
Well, I've always felt that when you get down to making policy and you look at the questions that have to be answered, there's no Democratic or Republican solution. You have to, what is the problem? How can we change things? And the whole exercise of looking at demonstrations of how to be more effective, save money, improve quality, was that a Democratic or Republican objective? That just seems like something that everybody would rally behind. And I guess if some congressmen institutionally say, well, that money's automatically being spent by the ACA and we don't have the opportunity to appropriate every year. Well, there's not a lot of sympathy for that position when you're getting a 3-to-1 return on the investment of the money, and when you work with the states, they're seeing the benefits as well. But you're doing so many different demonstration programs and trying so many things out. Do you think that too much is happening all at once and there might be a pushback to that?
I think it's hard for providers in today's world, and I think this goes back to the first point we were making. There's more and more demands to, it's not just CMS. We have private payers who are trying to put new demands on providers. We have other entities putting new demands on provider systems. And I think there's a certain level of, I think we've heard the term sort of opportunity fatigue from a lot of provider systems who are trying to do 6 things at once. And it's hard. It's really hard. So I think our challenge is, and I think Andy Slavitt, our administrator, when talking about that MACRA, that piece of legislation that I mentioned before, is that one of his goals is to simplify, and make this achievable for physicians and systems to be successful in this new world. That means things like aligning our quality metrics, figuring out how these systems can work together, trying to work in collaboration with private payers, like through some of those coalitions that I talked about, to be sure that we're trying to work together and put those together. But it is a challenge, and it's something that we need to continue to work on.
How difficult has it been in working with the healthcare system to get them to pay attention to public health outcomes? Because so often healthcare systems think about an individual patient, getting that patient the care that person needs, whether it's fee-for-service or other kind of systematic approach. But one of the things we also wanted to do is not just look at patient by patient, but public health outcomes. How much of a challenge has that been?
It's a huge challenge. And I think that the starting point has been, as we did in some of our initial ACO work, was at least to hold them accountable for the quality of care that they're providing. So what they're doing in the hospital, just make sure that what you're doing with that patient is of high quality. I think we are trying to push beyond that, and I think this is where, again, I think the real promise of state-based models and the opportunity for Maryland is once we get everybody into a system and we can structure a system that captures an entire population, the ability then to say to the system, well, they're all in your responsibility, and now we're going to hold you accountable for everybody, but we're also going to give you tools. We're going to help you make those alliances. with outpatient centers. We're going to help you make those alliances with public health. We're going to hold you accountable. For instance, we've talked in Vermont, for instance, about holding the entire state's ACO accountable for reducing substance use deaths across the entire state. What does that mean? How do we structure that? How do we give them the tools to be successful in that? So it's not just about putting the hook to them and saying, hope you're successful. It's about backing that up with trying to say, okay, how are you going to align with the successful substance abuse providers in your area? How are we going to help you create those data linkages that you need? It gets into very technical sort of nitty-gritty issues of how these systems can actually connect. But we want to put the incentives out there, but also create the tools for them to link so they can be successful in that public health mission and pull in the public health sector as well to really think about the health of the entire population. But it is hard. It is hard work.
Mm-hmm. Tell me how it's been in engaging physicians. Physicians at one time were strictly pay-for-service. And then they had the challenges of managed care HMOs, which wasn't always successful in getting physicians to feel that that's the way they wanted to practice medicine. How has it been with your engagement with physicians to get them involved in the change of healthcare? I know there are some financial incentives, but it's got to be more than the financial incentives, although the money does count.
Yeah.
Tell us more about how physicians have been interacting in your demonstrations.
And Henry, I remember when we first briefed you in 2009 or 2010, I guess, on or maybe before that, about ACOs. I think one of your first questions was, how can we make sure that these aren't just managed care all over again, right? And I think that was something I still think about, something I still try and try to build these systems to be sure we're.
When you think about it, do you hear my voice?
I do hear your voice, Henry. Absolutely. I hear your voice on a lot of stuff, Henry. And
I yours. And Josh's.
So I think the idea is really, and I think you put it well, which is that let's put the providers in charge. Let's really make sure that the people who care most about our patients and our beneficiaries are the ones that have the ability to be successful. I'm, as you know, a physician, and I believe that we want to do the right thing. We've been in a system where it's really hard to do the right thing all the time. And I think a lot of physicians have been very eager to think about a system where we actually pay them to do what they were trained to do. And at the essence, strip it all the jargon away. That's our goal in this delivery payment reform, value-based purchasing, whatever you want to call it. It's to allow providers to be providers. It's allow people to take care of the patients and get paid if they do better. And so that, in a sentence, is what we're trying to do. And people get that. The challenge is that we're making them do 6 different things. We're trying to hold them accountable for something that they don't have the ability to do. And so we have to put those pieces together. So I would say providers mostly, almost entirely, agree with what we're trying to do. There's a lot of frustration about the journey to get there and some of those steps that we need to get there. And I think we need to be sensitive to those providers and what they're trying to get out of this, and they need to keep their bottom line up, and we get that, and how to facilitate that transition. But at the end of the day, we're just trying to help make sure that we're paying them to do what they wanted to do in the first place, what they all went to med school to do, or to PA school or NP to school, and trained to do, was to take care of patients.
Well, that's great. Now, you're working on so many different approaches and measuring them and testing them and evaluating them. Let me ask you a tough question. A decade from now, what do you think we'll have? Will we have different states running different systems? Will we have one kind of system that other states will pick up when they see the success elsewhere, when they're tried out? Do you think that healthcare will become closer to single payer, not a single payer model, but a single unified system, maybe even a single payer? What's your projection of where we're going with all of this?
I don't know entirely, but I will say I think this piece of legislation that I put up on the slide, this MACRA again, is going to change things dramatically. It's going to really provide strong incentives for all sorts of providers, hospitals, physicians, everyone, to figure out how they can get into some of these arrangements of alternative payment models. And again, that's that jargon we talk about in terms of value-based purchasing. I think that's going to have legs. I think it's going to continue for the next decade. I don't think this is going to be a flash in the pan. We may take a breather in 5-7 years and say, this has gone well, this hasn't gone well. I hope we take checks on this in a very frequent fashion. And we at the Innovation Center are trained and believe in taking very frequent looks at how we're doing. And I'm hopeful we stay on track in terms of helping ensure that we address providers' needs, improve care, reduce costs, and improve the real health of the population. I think all those pieces coming together, I think there's money on the table under MACRA to really drive that conversation in a way that even our $10 billion under the Innovation Center couldn't do. The sort of the magnitude of incentive that MACRA has changed is going to have long-standing impact. Now, Congress may change their mind. Who knows? We never know. But I think my current expectation is that providers are going to continue on this journey, partly because providers want to. As I said, they want to do the right thing. And we're going to continue to find ways to support them in that journey. And the MACRA incentives are going to continue to reward those who do well there. But Henry, let me bounce that back at you. You've been watching the healthcare system for 40, 50 years now. What do you've seen lots of flashes in the pan. You had the managed care experience. Do you see this as another managed care experience where we're going to end up with cursing ACOs in the future? Have we addressed your question, I guess, of 2 years ago?
Well, I'm excited about the things that you're doing and that the direction that we're moving the healthcare system, because so much money is at stake, so much money is being spent. And it could go on and on and on, and people worry about spending. But this approach is to get good quality, cover populations, meet individuals' needs, and bring in the whole provider community in a way that the system works together for everybody. I'm struck by the fact that when we had our session on Medicare early on in my term as the Centennial Scholar here at Johns Hopkins Bloomberg School of Public Health, Karen Davis made the comment that when Medicare was adopted, President Johnson was so sensitive to the attacks that the government was going to run the healthcare system that he wrote in the law that this law should in no way impact the delivery of healthcare. And no one could imagine that with the adoption of the ACA, the Affordable Care Act, that we didn't mean to impact the delivery of health care because we wanted not just to cover people, but bring the system in a more comprehensive way to provide for the needs of the populations, the individuals, and all the payers, taxpayers as well as others. So I think you've been very helpful in helping us see the direction that we hope we're going.
I remember that was during the ACA debates. That was one of the Republican amendments, and we had to stand because of what you just said. Basically, the talking point you just gave was what we had to talk about then as well. So this theme has come up again and again. So,
yeah. Well, I think we ought to open it up for the balance of the time we have to get questions from people in the audience.
Well, thank you very much. We have microphones on both sides of the auditorium, so I'd invite people who would like to have an opportunity to ask a question to come forward. And if you would identify yourself, that'd be helpful.
My name is Steve Sharpstein. I have a slight relationship with Josh Sharpstein. And right now I'm beginning to work in an interesting setting, a community clinic, an integrated care center, with folks with lots of problems, not just medical problems and multi-medical problems, but also other problems related to the environment that they live in. What I'm struck is that we're not paid enough. What else is new? And I'd like to ask you about the science of risk adjustment. That in the context of trying to become value-oriented, the quickest way to make money is to shift your risk. If I could change the patient mix to a different patient mix, I know that our clinic would make money. But we can't. So can you say something about the science of risk adjustment and how it applies to payment models right
Sure.
now?
So I would say there's a lot of money and attention, a lot of consultants hired to think about that question. I'm not sure anybody has a perfect answer. I think there's never been a resolution to that debate of what the right risk adjustment tool is. I think we have systems where we're trying to apply those tools as best we can. None of them are perfect, and I'm not going to sit here and pretend like they are. I will say there's another approach, which is, I think, the potential approach that is represented in Maryland and some other states, which is to set aside the question entirely and rather to draw your circles big enough that the risk of a particular population doesn't adversely impact one provider as much anymore. So when we think about building systems that have big denominators, everyone's going to have some of those populations in there. Everyone's going to have to figure out how to take care of them. And we hold them accountable, by the way, for being sure that the needs of those populations are addressed. But that risk becomes less ability to game that, I guess, if we talk about, say, a geographic denominator. If we draw circles by geography, you can't send your patients to the hospital down the street. They live in your zip code. Take care of them or let someone else take care of them badly, it's still going to be on you, right? So there's a framework here where we can sidestep the risk adjustment question, because until we think about how do we hold systems accountable for populations, we're never going to solve that right. And there's always going to be more tweaks we can do because no model is perfect. It does not exist. And so what we can do in the current world until we get to that point is use the best science we can. And that's what CMS is absolutely committed to do. We have multiple conversations, multiple expert panels convened, multiple conversations with NQF and others about how do we do this. And I will say the last thing on that is that we have to be careful with risk adjustment and that we don't risk adjust out disparities. So meaning that we don't want to say you have a lower SES, it's okay if you don't do as well on quality. We got to be really careful about that. And so that's why I'm saying there's no perfect science, because I think it comes down to questions that are almost unanswerable, which is why I think we, at least from the State Innovation Group perspective and from the Maryland perspective, you have an opportunity to sidestep that question. And we'd like to think about what that might look like. We're not there yet, but I'd like to think about what that might look like.
I had the privilege of serving with Dr. Sharfstein Sr. under President Jimmy Carter as fellow Public Health Service agency heads. I was at a forerunner of HRSA, and Dr. Sharfstein was at the National Institute of Mental Health. And so I thought what he was going to ask.
I thought he was going to ask something else too.
Maybe the question in the back of his mind was how well the state innovations are beginning to integrate behavioral health with healthcare and primary care, and what's exciting that you've seen about what states are doing, since states traditionally have been responsible for behavioral health.
I thought I was going to ask that too, by the way. But
My second question.
I would say there isn't a state that we're working with that is not doing something around this area. It is absolutely paramount. And you know, I have a slide that I sometimes use for Medicaid. If you look at the top causes for readmissions for Medicare, it's your usual stuff. CHF, heart disease, COPD, stuff like that, right? If you look at the top 10 causes for readmissions in Medicaid, it's substance use disorder, it's maternity, it's mental health, right? It's a whole different set of diagnoses. So if we're really trying to make our systems more efficient, and not that readmissions is the only phenomenon we're concerned about, but if we're looking for those sources of inefficiency, it's about behavioral health. We have to tackle that. So I think it's exciting to see we're seeing some states co-locate, meaning putting primary care and behavioral health together in the same physical location. We're seeing other states enhance the connection, meaning they have almost like a hotline between the two, certainly better data exchanges. We're seeing a whole spectrum of what we're seeing out there in the state innovation model. And since this is an academic forum, if I have one thing that I say, it would be really great that we don't have bandwidth to really look at and dig at under really well. It's the spectrum of what's happening in our state innovation models for behavioral health and the impact of all these varied interventions. It's exciting. We're seeing some states have impact. I'll just use one state, Vermont. Vermont is seeing huge returns on their investment on a community-based intervention program where they have community-based workers that are working with people with substance abuse and high-intensity needs and making sure they get connected, making sure the community needs are addressed. And they're seeing not just we're breaking even, they're seeing returns on their investments. So we're getting more money back than we put in for some of those dollars, which is remarkable if you think about the high needs of this population. So we have little snapshots that we're seeing, okay, this works, that works, that works. We need to put that together in a much more cohesive fashion, and that's something that we'd love partnership on.
Good. So, Dr. Wu?
Thank you all. This is a little bit of a detail, but in Maryland, we are privileged to have a great burden of alcohol and drug abuse. And current regulations for confidentiality of records preclude us and precluded us in our own CMMI project from getting access to any of those records. And therefore, we couldn't either identify people at greatest risk or see if we made a difference in outcomes for those folks. Is there a fix that could be arranged one way or the other?
Just like that. So what you're talking about is, the technical term is 42 CFR Part 2. This is absolutely something.
Yeah, why didn't he say that?
We've talked about that with a lot of partners. Two answers to that. One is that there are proposed rules to think about modifying that. I can't honestly remember where we are in that track. I sometimes forget what I've seen and what's public and what's not, so I might want to say anything because I might get in trouble. But there is work in progress on that. That's number one. Number two is that we have seen states that have been able to work within the context of even the current laws and regulations. So as a state innovation model, we've held webinars and forums for states to talk to each other about, hey, this worked for us, that worked for them. To the degree Maryland wants to raise their hand for some of that TA support, we're happy to help support that. None of the solutions are ideal. I'm not going to pretend like, oh, it's easy. But there are ways that states have been working within the current context. And I think there are ideas about trying to think about revising this over time.
Thanks.
Dr. Welling?
Hi, I'm interested in your thoughts on the limitation of the cost neutrality part of the mandate for CMMI. I'm thinking particularly about some of the innovative models that for high need populations you might see them meeting the needs of that group, but it means an increase in care at the beginning. And to really see the effects of care coordination, for example, it takes a longer time to see the benefits. But for some of these innovative awards, the evaluation time is quite short. So I'm wondering what your experience has been and your thoughts on perhaps making changes so that we can really see the benefits of some of these innovative models.
Absolutely. So I think that, it doesn't have to be in every given year. It has to be over the life of the model. Usually our models are 5 years, but to be honest, that's not mandated. It's just sort of our standard practice because it's about enough time to get the model stood up and start to see some returns on those investments. But if we needed to see a longer model, I think there's nothing that prevents us from saying, okay, we might need to build a 6-year model or a 7-year model. I think there's nothing that says we can't do that in order to recoup those returns over the out years. I think we're seeing, for instance, with our comprehensive primary care initiative, which is our version of patient-centered medical home primary care transformation, we're seeing returns. We haven't yet paid off some of the initial investment, but we're seeing changes in the net spending on Medicare such that we're hopeful, again, we can't know until we see the data, but we're hopeful that if that trend continues, we'll end up in a good place with respect to cost. Just to say, I think we understand the need for front-end investment. It doesn't have to be year over year. We could even extend multi-year models as we need, depending on the nature of the model. The other answer, and I thought this is where you're going and you didn't go here, but just to say as well, there is something, and we dealt with this on the Hill with CBO as well, which is that when people live longer, they cost more. So when you save lives, your model costs more. And so we have said and argued, and both to CBO when I was on the Hill, as well as to our actuary, that those should be held in a different bucket. That I understand that it may cost more, but it costs more because people are living longer. We should hold that cost and consider that cost in a different way. And I think with the diabetes prevention program, I think we're successfully having some of this discussion. And still, all this is still in motion, but I think these are the kinds of questions that we're trying to struggle with. Should living longer cost more? Should that be held? Should we be penalized for this? We think no, but I think we have more discussions to go. And I think what we got to CBO was to say at least separate those out in another bucket. But this is an ongoing challenge.
I think in some areas, we're increasingly seeing shortages of highly specialized individuals. Medicaid for a long time has had problems with child psychiatrists participating in the program or even being available. And I know states like Massachusetts have found a team approach to care where, say, child psychiatrists can provide support to primary care physicians by telehealth or telephone backup so that they are able to handle more of these problems. And I know there are new models that combine mental health professionals with primary care, with nurses that may be doing home visits or care coordinators or community health workers. So what do you see in these state innovations that are really moving us more toward a team approach to care, both to deal with shortages of certain types of specialists, but also with the cost issue?
And I love that Massachusetts model. They've had great data back so far. And the model is essentially you provide phone support. So if I'm a primary care doc, and a pediatrician in particular, and I have a kid with special needs, or I can pick up the phone and have in real time somebody on the phone to talk to me. I mean, I certainly don't have that in my practice now. And so there's a real investment towards that. So I think there's a lot of promise for those approaches. But I think you're pointing to two things. Number one, reimbursement, which is we need to be able to pay for that in different ways. I think particularly with our sort of patient-centered medical home, health homes, PCMH, all these acronyms, it's really designed to provide more funding for that primary care infrastructure so they can take care of patients in the way that makes the most sense for them and break that out of that just 15-minute visit. So that additional investment can go towards that phone support or having a care coordinator or some of the more, without needing to see the physician necessarily and address their needs in different ways. So I think there's reimbursement, and in particular reimbursement for some of those telephonic services, which are hard right now in a lot of states. We're moving down that path, again, jargon, but there's this project called Project Echo, which is we have 2 states moving towards. New Mexico is in fact funding it right now. Colorado is implementing it right now into their payment system under the Medicaid programs. So there are ways that we can, and we've been trying to push, and that's not the Innovation Center, that's Medicaid, CMCS. So there's a lot of movement in terms of trying to think about how we can support these under our existing authorities, and I think that's really exciting. At the same time, we need to think about structuring those teams so that they can do their job well.
So if you'd identify yourself.
Hi, Steve. I'm Krista Spiker. I actually work at CMMI with Steve. I just wanted to add, I think, to speak to your question about the integration of behavioral and physical health. Health Homes is 2703 of the Affordable Care Act, is designed for states to develop models to integrate physical and behavioral health. And I think it's really important. States can receive 90% enhanced FMAP to provide care coordination to their super utilizers, their most chronically ill populations. And states like New York have developed these programs to work with their HIV/AIDS population, IDED population. They've really expanded that scope, and they are seeing savings currently under Health Homes. So it's a smaller provision of the Affordable Care Act, but it's crucial for Medicaid, as these services have not really been paid for like that specifically before. So that has an ongoing evaluation they'll be looking at for several years to come. So that'll be interesting to see what practices we can take from that and how it's best serving those populations. So just wanted to share that.
Another area for research. So.
Yes, introduce
Oh,
yourself.
sure. Hi, my name's Christine Trong, and thank you for coming and talk. It was really, really interesting. Right now, I'm currently working in enhancing depression care delivery to underserved older adults. And you've mentioned that you've seen in Vermont and Massachusetts an integration of behavioral health into physical health, like with the co-location or the phone linkages. And I was wondering if you could share a little bit about what you've been seeing in Maryland, the trend over here, and maybe you could share your thoughts on how things might go in the future, especially with, like you mentioned in 2019, you might implement that, or talk about the total cost of care model. Maybe throw that in there a little bit. See your thoughts.
Sure.
Thanks.
So before I start, I just want to be very careful to say, the beauty of the Maryland model is that it's the state leading. And I think we as feds are in a supportive manner and trying to be partners with them. But really, it's critical that this be a Maryland-driven solution. It's critical that this be your providers, your stakeholders, your folks really coming up with the ideas. We're happy to engage in the conversations. So I'll make a few comments, but I want to be clear that this is not CMS talking, but really what we're hearing from you in terms of ideas about what might happen. So we think that there are a few steps, one of which is probably on the way already. I'll set aside this idea of gain sharing, but what we think the next step really is primary care transformation, which is really an idea that we have this hospital global budget, which is fantastic. How do we support that primary care infrastructure in Maryland to come to the table and really be a part of this system and solution? And I would point out that unlike, we talked about this earlier with faculty, unlike other states where if a primary care practice gets payments and reduces readmissions, the hospital loses money, right? In Maryland, that hospital makes money, right? And so it is a win-win to really invest in the primary care transformation in Maryland. It's a unique circumstance to promote that kind of alignment. So we think there's got to be some kind of primary care transformation. We think that's probably got to reflect some of the elements of behavioral health, some of the elements of coordination and team-based care, and as well as some of the elements of what we call accountable communities for health in terms of, and some of the hotspotters and superutilizers. So there's pieces that can build into that. But just imagine that world for a second. You have a hospital global budget, you have a primary care-based transformation world. Then if you want to make that next leap to a total cost of care model, then it's really just trying to redraw the financing, right? I think the challenging part is going to be developing the delivery system to match the financing. Once we have this robust system of global budget and primary care transformation, then we can think about who's accountable, who are we going to hold on the hook, what does geographic-based accountability look like, to the point made earlier, how can we sidestep these risk adjustment problems that are never going to be resolved well, and how can we promote payment that aligns with the goals that we're all trying to achieve. And critically, my number one goal here is, at the end of this all, have we built the system that actually improves the health of Marylanders or not? That's sort of the key question that, at least from a CMS perspective, we're going to be keenly paying attention to. Because I think we're going to, particularly given where we've already gotten in our savings, I think we're going to get to we're going to cross the savings threshold, and we're going to maintain that. The question as we come on this, again, the jargon of total cost of care model, forget that terminology for a second. It really is just, how do we get the whole system to work together, and how do we build incentives for the entire system to work together well? That's the key question. And have we built incentives that promote the health of Maryland? So in a rough sort of outline, that's sort of where I think Maryland is talking about going. As CMS, I think we're supportive. The one question that I have asked is that one question that I just said, which is, the design is Maryland's job. I think from CMS, we have a statutory obligation to improve health. And how are we going to hit that statutory obligation? We're happy to work with you to share lessons about what's worked in other states, but this is Maryland's decision. We're here to support, but it does need to improve health.
Thank you.
So we've talked about primary care transformation. We've talked about payment transformation by moving from volume-based payment to value-based payment. What we haven't talked about very much this morning is transformation of the health information technology support. You work for Congressman Waxman in shaping the American Recovery and Reinvestment Act that obviously had the high-tech provisions. I was at the Commonwealth Fund. We looked at, I personally was invited to go and evaluate the Danish health system, and I was for the Danish Parliament, and I was very taken by the fact that all of the information was in one, what we would call a health information exchange. So hospitals put their records there, doctors put their records there, pharmacies, lab tests, specialists. Obviously, they did have a single payer, but it was an integrated health information system. And certainly, I think we would all agree that high tech transformed the adoption of electronic medical records by hospitals, by physicians. We did annual surveys tracking where the U.S. was versus other countries. We were way behind. We've largely caught up, and even the functionality of our IT systems sometimes exceed those of other countries now. But what we didn't, Congressman Waxman, what you didn't put in the bill was a single health information exchange. Where you might have a social security number or a common identifier for a patient, and all of their medical information would be in one place and accessible to all, with their permission, all of the doctors and nurses providing their care. So I know a number of states have developed multi-payer health information systems, not necessarily payment systems, but the IT systems. So I'm curious whether you think the transformation of the way we move toward multi-payer health information exchange systems is also a part of this transformation.
Yeah, I mean, I think, again, we probably sent out about $1 billion in cooperative agreements to states under the state innovation model. I would say probably HIT, HIE, Health Information Exchange, I won't try and use acronyms, are one of our biggest sources of what the states are spending money on, including all payers' claims databases. So I think the states are investing in this that we're working with. I think they realize that this is a key infrastructure piece for them to be successful on the multi-payer reforms that they're all working on. But it has been challenging, right? So you think about and I'm a primary care doc. I'm a primary care doc that understands, from a policy perspective, I understand the value of HIE and HIT. Also one of those guys who curses my HIT system, probably on a weekly basis every time I'm in clinic. So we have interface challenges with physicians. We also have how these systems not are just interoperable the way that the ARRA, the legislation made it, but actually working together in the way that we need them to, which is sort of an additional hurdle of interoperability. And I don't pretend to understand these except to say that we don't always get out of them what we think we want to get out of them. And I think part of that is privacy. Henry, maybe you can speak to some of the debates. We had vigorous debates about privacy and that information at the time of passage of the Recovery Act. But what we're doing now with the states is really trying to build all payers' claims databases that can achieve the mission that we, I think, once set out to do. I think there is this other factor of a Supreme Court decision that really hinders our progress there in a certain way. It allows self-employed plans to pull their data out. The state cannot require a self-employed plan to put their data in. So this is going to be a challenge we're going to have to address. And this is something a lot of people have asked about lately. I think my point there is that if they want to, they can. And I think it's our job, and I think this is my, one sentence answer to your question, is that if we build a system and build a reform where all the stakeholders see the value of providing that data, we can sidestep a lot of the problems around what people don't legally are allowed to pull their data out or for. In Vermont, for instance, where the lawsuit was that gave rise to the Supreme Court decision, we have most of the data sources in right now because they all see the value of what we're trying to enter into in this Vermont model. So I think we have to provide the value case. And that the legal decision puts a new challenge for us to say, here's why you should want this to the employers and to the third parties. to say, here's why an all pairs claims database has value to you. Here's why this very abstract technical concept of a health information exchange should have meaning to you. That's hard because it gets so technical so quickly. But I think we have to learn plain speak around this, and I'm not there yet. But I think we all need to get there in terms of making that value case for these investments. But there are serious privacy concerns, and we had long conversations back then about what could or couldn't go in the Recovery Act as a result of that.
I often tell students that this is the most exciting time to be entering the health field because there's so much change. And then when I talk to healthcare executives, I see that fear in their eyes. There's so much change. But I guess my closing question is really for our students. What are the opportunities ahead, and how should they prepare themselves to be part of this transformation movement? What would you most like to see them do?
I'll let Henry have the last word here, so maybe I'll go first here. But I think from a school that has such an amazing history of really thinking about these problems from a population level and a history of understanding how health systems work, that chance to bring those two bodies of knowledge together. And I think I started out with the ACA and ended with Maryland because I think that the opportunity is to make health system and delivery system reform, this technical term that usually means things like ACOs and just all this litany of acronyms, but to make that meaningful for the health and the public health of a population. That's where the turning point is for us now. That's where the next phase of our growth is. That's where we need expertise from public health schools and experts to understand how do we do this well, to combine that expertise around what works in public health with the incentives of a health system. How do we marry those up together and make that into a functional system that achieves the goals that we all want together? I think that's really exciting. It's what we're trying to do. I think we're trying to understand how best to do this. We're learning as we go, but that's the opportunity for your students and the faculty in here to help guide us on this journey and help inform the system how to do this well. That is to say, there's a way to look back and say, what have ACOs done? I'm interested in looking forward and saying, what's the next challenge for us, and saying, how do we actually make health systems improve health? That's the question to me in one sentence, and we're really excited about doing that, but we need help because we're struggling with how to do that well.
Well, if I get the last word, my comment to the students would be that when I certainly entered the health policy world, the debate was only in the context of patients and providers, and not in the purview of providing public health benefits to the population. The provider, patient, but what about the whole population? And I think we are at an exciting time when we see thinking and innovations that bring the two together, especially for students in the School of Public Health. You're not segmented that you only care about public health and the medical school cares about individual patients. We want the whole system to reflect both goals. And the ACA and the work you're doing, I think, is going to get this there.
Well, on that closing word, join me in thanking Congressman Waxman and Dr.